musculoskeletal trauma, extremity trauma. So I deviate from the actual slide a lot. You guys are getting towards the end of trauma actually, so start tying stuff together. Okay, we cram a lot of stuff in a short period of time, so you guys really have to do the leg work and start bringing all your trauma together. Pretty soon you'll be doing full assessments, you'll be testing out, and you'll be done with it. You'll move into medical, and trauma will be in the rearview mirror until you get to your final in your national registry, okay? The upside to that is trauma is always trauma. When you go to paramedic school, if you go that far, it doesn't change. The only thing you do different for trauma is you use needles, okay? You stick people. You give them fluids. You can correct more hypoperfusion issues, okay? Other than that, it's constant. No car wreck is the same. They're all different. I've seen stupid stuff. I've seen this last week a car wreck where a person's leg, it was actually dislocated. You'd see the edge of the tib fib, and the ankle was off, the actual foot was off beside it, and kicked up and angulated from a little fender bender, probably at 20 miles an hour on 31st Street. Okay. I've seen people pile into a tree, ricochet off their stuff and hit an oak tree that two of us couldn't reach around, and smash in the side of it, and we went in and extricated them. There's nothing wrong with them. I mean, you're going to see everything. It's never the same. Index of suspicion based on mechanism and injury should always be high. All right. Ever figure that? Bones, muscles, cartilages, tendons, and ligaments. Who can differentiate between tendons and ligaments? What do ligaments do?
Attach bones to muscles.
No, they help you make movement, or they help you move.
Anybody else? What's a tendon do?
Attach muscle to muscle.
Yeah. I have an analogy that I use for ligaments because I could never always confuse them back and forth. I have the general principle, but I made an analogy to remember ligaments. Ligaments go to bones, so I said lick a bone. All right. Who's had A&P? A&P is a good class to take. All right. If you're going to go to paramedic school, you're going to have to take it. They make you take intro to A&P, just as a sidebar for anybody going into this. If you're going to go further than that, introduction to A&P does not transfer. Okay, does not transfer. But it's good enough to get credit for an associate's degree in paramedicine. You can do A&P 1 and 2 if you have time, 2 semesters, much more in depth. Credits transfer, you'll know more. Intro to A&P, though, is still a very good class. You'll learn what you need to know a lot, the concepts and how things work. When we talk A&P, you'll do bones in the hand, blah, blah, blah. You're not going to get hammered on that, okay? You need to know stuff like, that's a skull. Okay? That's your C-spine. That's your thorax, lumbar, sacral, coccyx. What else? But all like this manubrium, you're not going to be tested on that. The big flat plate on your chest bone. Good to know if you know it. Xiphoid process. Costal cartilage is good. Connects these ribs. I don't know which ones. I think it's 5 to 9 or 10. 10, right? Sound good? All right. I think we'll see here in a minute. Clavicle's a big one. Understanding basic concepts like the scapula or your shoulder blade in that collarbone basically holds your arm onto the rest of your body. You break this or this doesn't work. Okay? Pelvis. You break this, that doesn't work. All right? Knowing things like how much fluid is held in here. Anybody? Anybody?
Anywhere.
In the pelvis, how much fluid can be stored in there?
A lot.
Anybody want to start out with, how about it? About 2 liters. plus. Okay, so an old person with a broken pelvis, can it kill him? You bet. Right? Long bone, femur, how much?
3.
No, not that much.
180 pound person, 3 pounds, 3 pints.
We go liter and a half is about what we use as a rule. Okay. You'll learn through time and experience dislocations of the femur head, how feet, legs are shortened and rotated one way. It might mean a dislocation versus a fracture. Okay. You don't need to know all these little things. It's good if you can learn them. Know main structures: femur, tib, fib, radius, ulna, humerus, shoulder bone, clavicle, sternum, obviously the ribs. You'll be tested on things. You've done thorax, right? How many ribs are there? Floating ribs. Okay. So don't sweat this. If you learn it down the road, great. Point is, skeleton supports against gravity. It helps so you can have movement, protects organs in your thoracic cavity. Production of blood cells happens in there. That's why there's lots of storage. Storage of calcium and phosphorus. All right. Might want to kind of be real familiar with some of these. These are good to know on especially the head and C-spine, thoracic spine, lumbar spine. Know that kind of stuff. It's good to know when you're doing a report that said they had a 1-inch laceration above their, just right of midline over their right eyebrow, or I felt a hematoma on their occipital plate. Okay, is that the occipital plate? Yeah. Temporal region. Okay. I don't know the exact word for it. Parietal frontal. I think that's parietal temporal. There's a lot of names you'll learn if you go in depth to A&P. You don't have to name every bone structure. They say they have a broken wrist. You say right fracture to the right wrist. You don't need to say, oh, the 7th metatarsal was. We don't need to know that yet. Okay. If you know it, oh, okay, so be it. But not pertinent. But know the major features of the skull, major bones, and all the spine. That really helps out. So when you're doing trauma, we all done head to toe stuff, touch, head, C-spine all the way down. How many C-spine?
7.
7. Right. How many thorax? 12. So if I get down and I go, oh, she has a step off about the T10. Okay? Being familiar with how many and about where they're at, I know that T12 is going to be somewhere where my last rib is at. It hooks into it. Okay? Knowing stuff like that's going to help you out. The big one we'll talk about here in a second, the foramen magnum. There's a big hole right here in the base of the skull, basically where your brain and your spinal cord connect. Okay? That'll come into play down the road when you go into head trauma as far as strokes. Okay? We'll cover it a little here tonight too, but you'll see it again. So your frontal bone, they talk about all these sutures, nasal bone, parietal bones, temporal, lacrimal. Great. Those are the major pieces. Mandible, maxilla, zygoma, and nasal bones. In A&P, you got to know that. You don't have to know that real well. Know this. This might have to spit this out. C1 through C7. C1 is atlas. 2 is axis. Thorax, T1 through T12. Lumbar, 1 through 5. Sacrum, S1 through 5. Basically fused in many people's, they don't differentiate. They call, I got possible tailbone fracture. Okay, we don't get called very much for that. Okay. This is heavy stuff. 12 pair of ribs. You got your sternum, protects the heart. protects the lungs. So this is some bone, but a lot of cartilage. This is cartilage. Some people, you see indentations on them where it doesn't fuse to the sternum. Not a big deal. It's just the way it came about. Okay. So you'll know when you're doing, you'll learn them as you go. But your rib number 1 is typically right underneath your collarbone. So right here somewhere, that arch is coming back. Okay. So that they talk about intercostal spaces. I'm sorry, or they say inner space. We call the space in between the ribs the intercostal space. All right, so 2, 3, 4, 5, 6, and then 7, 8, 9, and 10 are all on this one piece. This is your costal arch, or margin. Okay. You can get tears in those, inflammation. People that weight lift can get an inflammation and actually break the seam in there. You're not going to know that if you ever find that. Unless they have a history of it, they'll tell you. Okay. But knowing 7 through 10 are on the costal margin, 11 and 12, 12 barely comes out. They're floating, you know that. You'll be familiar with C 1 through 7, T 1 through 12, lumbar, kind of know your ribs, all right? Clavicles. We're always checking for clavicles on big traumas, okay, especially frontal impact. It's when I clear your head and neck, it's probably one of the first things I touch is somebody's clavicles. I reach in, a lot of people say, I'm fine, and you push down on them, and they scream. Pretty obvious what's happening. You will cut their leather off. They don't want to take it off regular, I promise. They'll try. Okay. Pelvis, bony ring, 2 inanimate bones, which are made of 3 fused bones. The ilium, the ischium, and the pubis. This, obviously, bone socket for your femur. This is called the acetabulum. Pretty common fracture in old people. They fall. As opposed to their femur breaking, that socket will bust open. A lot of blood, 2 to 3. Diane, when she was in here, that's what she said. Her stepmom just fell, fractured pelvis. People are coming in. Doc told them 50-50 if she can eat because she's got poor health. 70-some years old. You know somebody that gets a pelvic fracture, older people, it is serious. Some of us call it the beginning of the end. Okay, old people get a pelvic fracture and they have a good, clean health. They might come out of it. A lot of them, they start developing problems from there on out. It's a very, very traumatic injury. A stupid little fall. Okay. Might take 2 years. It could kill them. Lower extremities. Obviously the femur, 1 to 1.5 liters fluid. Patella, kneecap, tibia, tib, fib, tarsals, metatarsals, phalanges, blah, blah, blah. Have you all done traction splints yet? Okay, so you learn traction splints. Talk about mass pants. You can do mass pants to fix one of these that's broke, or both of them. You can use mass pants to fix that if that's broke. You can do a traction splint if one of these is broke. We'll teach you when and when not to use them. You won't use traction splints very often, but this is one of the most painful fractures besides the pelvis that you'll come across. Okay, hands down. Biggest group of muscles in your body, they want to contract. So when that bone breaks, the muscle pulls together and the bone will bypass each other. What's in my leg right here? Yeah, artery. Now take a bone that big around with a jagged edge on it. Bleed to death? Probably so. Nerve damage. So we'll teach you treatment of that will be a traction splint. And it's very okay to do it. You're literally pulling the bone ends apart. Okay, you're stretching their leg out. And we'll teach you when not to use it. These people, this is ALS. If you find this and you can get ALS back up there, absolutely, based on blood loss. You want to control pain. Okay, we'll give them happy drugs. A lot of these common in car wrecks. Big deal. Everybody breaks a leg once in a while. Not a focus. They might be screaming about the lady that had the dislocation, was screaming bloody murder. Her and her daughter were in the car yelling prayers. Jesus Christ is going to help you. He'll get you through this. I'm like, hey, why don't you talk to me for a minute so I can look for other, that's called a distracting injury. Screaming about something like that. Okay, frontal impact. Think here. When I got her to calm down and talk to her, she said, yeah, my head hurts. I have a headache. Did you lose consciousness? I don't think so. That means, yes, I passed out. I just don't remember it. Okay? C-spine, ABCs. Upper extremity, we'd already talked about this a little bit. The girdle, scapula, clavicle, hold your arm on to your thorax. Humerus, that's a pretty painful fracture if you ever come across somebody that's broke that. We'll teach you how to splint that. We think splinting boards and casting and all this stuff. People that break their humerus, we put a rag around them. Okay, we let them guard. You'll approach them and they'll be just like this. Okay, they'll have their arm up like this to guard against it. They don't want you to touch them. We'll teach you how to sling it up and put a swath around it so it doesn't move. Clavicles, they'll present the same way. If it's come apart and actually has a bulge or misaligned, they'll be guarding as well. They'll hold their arm. Won't be as high, but they'll hold it anywhere where there's no rubbing up here. So you got your radius. Which side is it on? Is that anatomically correct? Hands out or hands in?
That's right.
That's right. So the radius will be the lateral aspect of the right forearm. Or if you know it's a fracture of the radius, because it's sticking out of their arm, you can say, patient had a fracture of the right radius, or I suspect a fracture of the right radius. We don't get into hand bones and stuff. It's broke, it's broke. We're not going to do much. You're not going to die from it, okay? Any questions on these so far? If anybody ever has a question, interrupt, okay? All right, so C-spine, that's just another picture, covered all this. Any questions here? Moving on. Bueller. Okay, muscles. They maintain posture and they provide movement. 3 types of muscles. You're going to see this again. Okay. Bones give you shape. Muscles maintain posture and allow for movement. You'll see that. You'll see 3 types. Skeletal. Smooth. What's an example of a smooth muscle?
Biceps.
What?
Bicep.
No, wouldn't it be like your intestines?
Intestines. Mesenteric muscles, they're called. What else? My lungs, blood vessels. Your body dilates and constricts them as appropriate. Okay? They're involuntary. They do their own thing. Right? Skeletal or striated biceps. They make movement. You make them move. All right. And then the 3rd type is cardiac. It's isolated to itself. They are super duper special. They don't, let me not say it like that. There's a course of muscle built into the muscle that conducts electricity so that your heart beats. There's no other muscle anywhere like it. When it's dead, it's dead. Okay? We can repair a lot of the skeletal muscle, smooth muscle. I'm sure some of that regenerates, but things like emphysema. People that smoke nonstop contract for 40 years, contract emphysema. They've destroyed the lung tissue. Your alveoli don't expand like they're supposed to. That typically doesn't come back. When it's dead, it's dead. That's why they develop disease processes called COPD, which you'll learn in medical. All right, voluntary muscles attached to bones. You got that tendons. Attached to bones by tendons that cross joints, short A shortening of the muscle moves the joint. Shortening of the muscle moves the joint.
Pretty sure that's the other way around.
That's what I think too. Tendons attach to bones. Okay, so I'm backwards again. We'll get back to that in a second. So, muscles, tendons attach muscles to bones. Ligaments attach bones to bones. All right? Everybody got that? Because I clearly don't.
Wait, what?
We'll cover it in the next slide if you want to wait. Don't scribble scrabble too much.
Okay.
All right? So the shortening of the muscle is what moves a joint. So when you're in the mirror, who's got buddies that get in the mirror and do this crap and take pictures and put it on Facebook? I got a couple firefighter buddies that do that. I'll make fun of them.
Jason?
Who?
Jason?
No. he would most certainly be making fun of them. Smooth muscles carry out involuntary movements. They're located in the walls of the GI tract, the GU tract, respiratory blood vessels. You'll cover GI, GU with Leroy last Wednesday, right? Is that Wednesday? Yeah. Okay. It's eating and drinking systems. How you get rid of it. Cardiac muscle found only in the heart. It's automatic. It just does it. Can initiate its own contractions without any stimulation. Even your involuntary muscles. Your belly, it's stimulated. You might not be stimulating it directly. When you start eating, your eyes see food. Oh, I'm going to digest that. It just happens. So indirectly you control it, but you don't. This happens whether you want it to go or not. You can't, okay, you could stop it, but it wouldn't work out so good for you. It just happens. Here we go. Tendons and ligaments. I'm so dumb. I'm teaching you guys. That's pretty bad. Tendons connect muscle to bone. I'll forget this by next semester. I'll do the lick a bone thing and still be wrong. Ligaments connect bone to bone. Ligaments connect bone to bone. Either can be injured or has similar presentations to injured muscle. Legs, football players, people that start working out, that's a big one. You see that all the time. They started a new workout program and they went all in. I'm going to bench press 225 and run 6 miles today and run the bleachers, and I'm going to do burnout on biceps, and they haven't done anything in the last 6 years. And then the next day they're calling you. I can't move. Really? Okay. Cartilage covers bone ends to protect. It's like I want to say it's like oil, but it is. Structure to nose, ear, your costal arches, portions of your sternum. Okay. Joints. Joining points of bones. Everybody get that? Bone ends covered with cartilage. Again, ligaments connect bone to bone. I'm going to get this. Inner surface of the joint capsule is lined with the synovial membrane. That's the lube. See, it says lubes, the joint. All right. So different kinds of joints, ball and socket. We talked about that in the hip. These are hinges. They only go one way and they only go so far. All right. If you go the other, they'll go the other way, but then they're probably broke. So moving on into, any questions on that so far? The skeletal, that's real down and dirty crash course again. You don't need to know how many metatarsals and metacarpals and all that junk. Know the big stuff, be familiar with the main regions of the brain, or the skull. Really important to know the thorax, how many of them, they're in line with your spine, right? C1 through 7 when you hit T1 through 12. T1 through 12 is a rib coming around, okay? T11, 12, you'll probably see that they float. You might see a costal arch type thing, you know, the pelvis, you know, the major leg bones. Other than that, it's not too serious, okay? Moving on to extremity trauma. Fractures, break in the bone's continuity. That's a hand. Actually, that's the hand. That's the radius. That's the ulna. This is called a Colles fracture. All right? You'll see these in a minute. They're pretty common on people that fall forward and break their hands. You'll see them bilateral Colles fractures on people maybe they fell off of from height of some sort. Right. Fracture causes direct force, indirect force. What's an indirect force?
The one that isn't indirect to the breaking.
Y'all got that?
You hit it here and you break here.
How about lightning? Lightning? Get struck by lightning? You can be struck by lightning, goes in, muscle contraction with enough force to snap a leg in half.
That's
Okay. Twisting forces, diseases, osteoporosis is a big one that's dominant in elderly people, females, tumors, cancers. When you're going through a lot of these stuffs, unknown stuff, abdominal pains, trauma for unknown reasons, you can think ages. They talk about differentials that she was talking about. What could this be? I always throw cancer in. Cancer is always a differential. Okay, doesn't really matter right now to you because you can't do anything about it. You need to find the things that are going to kill. She says, I have abdominal pain. What are you thinking? I'm sidetracking, but that's okay. I got time. Right? Number one thing, she said it. Ectopic pregnancy. Any women, childbearing age with abdominal pain is ectopic pregnancy until proven otherwise. Why do we go with that one first?
because that's the one that could kill her.
It'll kill them. It can kill them quick. Okay? Appendicitis, bellyache, Crohn's disease, which is an intestine disease, diverticulitis, which is another kind of intestine disease, a flu bug. What else presents with abdominal pain? Cramping in the bladder, gallbladder, pancreatitis, gallstones, kidney stones. How about old people and diabetic have some kind of, I've got abdominal pain or like what they describe as acid reflux? How about a heart attack? So your list of stuff that can be is this big. Then you start finding ways to rule it out. If somebody, you walk in on and they're on the couch and they have their right leg pulled up and they're laying over on their right side. Not funny. What is that? They say, I have pain on my right side that radiates and moves to the middle.
Oh, I think it was.
It's appendicitis. But can I say, I have appendicitis here? Better be adding a bunch of stuff. But it's probably appendicitis. That's hallmark. Right leg raised up against their belly and they lay over on the right side guarding. Complain of pain that started just all of a sudden and maybe moves to the middle. That's probably appendicitis. I can rule out a heart attack. Okay? Probably.
That's interesting.
Okay, back to the main topic, fractures. See, I got way off there. That's awesome. Open versus close. Close, the skin over the fracture site is intact. Open is a break in the skin over the fracture site. Some people think an open fracture has to be a bone sticking out, and that's not true. Okay? The skin is broke, it's an open fracture. Roger? Are you tracking?
So in other words, if it breaks and goes back in, it's still an open fracture.
That's right. And that'll happen. So in an open fracture, the bone ends do not have to be exposed. A small opening in skin is communicated with the fracture site. Means it's open. Okay, means it's over the fracture site. Open fractures are more serious due to external blood loss, possible infection. It'll go out, pile of dog manure, and then go back in the leg. Yay. That'd be worst case scenario probably, but I'm digging deep here. You'll need to help me out. They're very painful. That bone moving around, we already talked about it, like long bone. Nerves, major arteries, major vessels. Lots of stuff can happen with simple fracture. Now if it's my arm's broken, it's a little distorted, then I think they've got a head trauma. I'm not worried about their arm. But if they fell off their bicycle and have an open fracture, and I know that's it, then okay, then you can concentrate. Open fractures are always pretty serious. Yeah, there's open fracture. Here's little coloring book pictures. Closed, open, breaking the skin. How do you call that open? Fractures, one of the most important things we do in EMS, prevent closed fractures from becoming open. So when I say their little arms broken, dangling all over, but there's a lot of other stuff going on, and we rip them out. We don't rip them out per se, because you don't want to make things worse, but it might not be the focus, but don't make things worse. We don't want it, especially if it's broken legs. Okay? It's a judgment call based on the patient you're presented with. You might work around here and be stuck with a paramedic, and you don't have to always make all the decisions, but you might go to an outlying agency that runs dual EMT trucks, because they're out there. Houston Fire Department. Big city of Houston, they run dual EMT ambulances. Okay? Oh, what's happening? Okay? You might be on scene. This is BLS. You can take care of this. Alright? So might be a car wreck. I've worked a car wreck where the lady's dying and her leg was broke. It was broken pieces all upside down, and I was looking at the sole of her foot. She's coding. Stops breathing. Yeah, I grab her leg and I rip, and rip her leg out. Literally rip her leg out. That happens. But she was dying, case by case. Okay? Don't make anything worse though, it's not necessary. Fracture types. Fracture transverse. You're going to see these. Okay? 90-degree, oblique. Spiral shows it kind of not so straight. You're not going to be able to see this, okay? You understand that? You're not taking x-ray machines in the ambulance with you. The only way you're going to see anything, you'll be able to see that. That. They look the same to me though when you pull a person out. But be aware of the different types. You'll probably be seeing this. These will be blatantly obvious. An angulated one could be the Colles fracture. It's more like angulated and displaced. Between that and that, you'll see it here in a minute. But you'll be able to obviously see that. You can see that on the clavicle on some people. Some will be intact and it'll just be a transverse fracture. And when they move it, the bone ends rubbing together, they feel the pain and guard. Or you're going to have something that looks more like that, and you'll actually see a huge deformity. You could see it here. This is the big one where they pass each other and they're displaced, and the femur is the other one. Okay, big muscle groups. Big muscle groups. They will pull by with a simple movement. You might be the one moving them that does it. Be careful. So spiral fracture coils through the shaft of the bone like a spring. There you go. That's kind of like the stellate laceration we talked about, right? Everybody missed that? The stellate laceration is a star shape versus cut across, a little word I didn't know. It was looked up. So that's what a comminuted fracture. Broken bones into at least 3 or more pieces. Impact is when bone ends are driven into each other. So fall from heights, jumping off a ladder. I don't know why it's common, but probably people off ladders, they lose their balance and they jump off and try and clear themselves from falling sideways. They jump off and try and catch themselves and they hit they land on their heels or fall back on their butt, they compress their spine. Seems to be the most common ladder injury that I've seen, just from my experiences. Probably not textbook, but you'll see compression. That'll be a large concern for you. Okay? Green stick. Shaft of bone is not complete. Excuse me. Again, green stick. Shaft of the bone is not completely broken. Compressed on one side, splintered outward on the other. Answer the question, who is it?
Children.
Children. Okay, they're still developing. They're more pliable. There's your Colles fracture. That's the little... What's the word? Oh, I'm so stupid. Displaced. Okay. You'll see these. People that fall, too much force. Your arms aren't made to catch you coming off the second story. They're just not. It says it has a fork-shaped pattern to it. Fracture of the distal radius. Fracture signs, obvious deformities. Some people might be just tender. It's usually point tenderness or the skin that overlies it, like on a C-spine. All right. Their inability to use a limb or their guarding, they protect against it, any movement at all. You should suspect a fracture. Reliable sign of significant injury is present if they can't use a limb. The reverse is not true. Okay? Just because they can use a limb doesn't mean that there's not a fracture. People go, can you move your hand? Oh, that's good, you're no fracture. I used my hand for a week on a fracture. Who's had a fracture, wasn't diagnosed for days, and used a limb? A portion of the people in the room. It happens all the time. Okay. But if you see them that can't use a limb, suspicion of a fracture should be pretty obvious to you. Okay. Other signs are swelling, obviously, at the site. Exposed fragments, crepitus. Leroy talked about that, especially on ribs. You hear crepitus. I'm sure he told you. You hear that? That's good enough. Document it. Tell the docs about where you found it. But don't call all your buddies over and go, hey, look at that. The patient's not going to like that. Okay? Can be heard or felt. There. Don't actively seek it. Don't make it happen again. There's dislocation. A displacement of the bone from the normal position at the joint. Again, deformities. Not always going to be able to tell if it's dislocated or fracture. Either way, you'll splint them a little bit different. If you have a fracture, if you see a deformity right here, we splint the bone, we disable the joint above and below. Okay? If you see that, say it's an elbow. You know there's something wrong, deformity in the elbow. We splint and we disable or we secure the bone above and below. Okay? You'll see that. We'll practice it. You're going to do so much bandaging and splinting next week. Every kind of fracture you can think of. If I can get, have you all had Tommy Peckall yet? He's our public information guy from Temple Fire.
I took his CPR class.
Oh, did you? He's a bandaging and splinting ninja. He teaches it better than anybody I know. Okay, you'll learn there's not one way that's right. There's ways that are wrong, but there's a lot of ways that'll get the job done. But he's pretty particular in specific fractures. You'll be taught. So signs, symptoms, location, deformity, swellings, ecchymosis, pain and tenderness of the joint, loss of motion, usually perceived as a locked joint. Ooh. Hip dislocation and or fracture. The affected side is shortened and rotated. I'm not going to sit here and lie to you and tell you that I can remember, because I can't. But one way is typical of a fracture and rotated in is the other one. One's dominant to whether there's a dislocation or a fracture the way their foot's rotated. But I'd be lying if I told you, because I can't remember. I just pick them up, put them on a stretcher, and take them to the hospital. Basically, when you get to somebody that's like this, you're going to do ABCs. You're going to realize they're not going to be able to move it, or it's going to be severe pain. If they try and move it, if you touch their leg, they'll scream out. Understanding when you do your inspection, you did trauma right. You go feel, squish, everything is not, you're not caressing. It's not a bubble bath show. You're getting in there and feeling it up, okay? You don't feel anything here, you suspect it's a joint, or you see the obvious sign like you saw earlier, you splint and protect that, whether it's the joint or arm. But before you do anything, you've already learned it when you did C-spine. What's the first thing we do when we do C-spine the other day? BSI safe, then what?
Measure.
PMS.
PMS. Every time you put something on somebody, the first thing you do is PMS, and the last thing you do is PMS. We want to know we have PMS in that foot. Okay, so when you move them and you secure them, you're very often going to put this person on a backboard or a scoop stretcher and put them on a flat board so they don't move around so much. And you're going to secure them. And when they're all secure, you want to make sure you didn't move them and take away PMS. Because if you did that and you're in gold plate transferring to scat and white, it's a long transfer with no circulation. Okay, you'll be taught. I don't know if our curriculum goes through it. We used to teach that you had one opportunity. If you didn't have pulses on your assessment, you have one opportunity to try and align it and regain PMS. That's can be a pretty risky maneuver. You will do it on a femur fracture though. Traction splints, and you'll learn it. Sprains, partial temporary dislocation results in tearing of the ligaments. Ligaments connect bones to bones. Bone ends are not displaced from normal position. Signs, tenderness, swelling, or ecchymosis. Everybody understand ecchymosis? It's the same thing. Swelling, bruising. Inability to use the extremity. No deformities. Sprains, degree of the joint dislocation at the time of injury can't be determined during the exam. But extensive damage to neural or vascular structures may have occurred. Again, PMS. Strains, a little muscle pull, injury to the muscle or tendon, pain on active motion, not present on passive motion. Okay. What time is it? Here we go. So your assessment. Perform initial primary assessment. Locate life threats. ABCs, fix life threats. Injuries head, chest, abdomen, pelvis, neurovascular function. What's that mean? PMS. I keep pushing on the button. With the exception of the pelvic, possible femur fractures, orthopedic, with the exception of the pelvis and possible femur fractures, orthopedic injuries are usually not life-threatening. Why are those life-threatening?
There's a lot of blood there.
Blood. We talked about it. Lots of blood stored there. Do not let spectacular orthopedic injuries distract you from ABCs on obvious things that kill the patients. You're going to see it. I had the lady that I said was screaming bloody murder about her little foot. The person that showed up on that scene to transport that patient, all he was concerned about was taking her to the ambulance, getting an IV started, giving her pain medications. Didn't have a clue what was going on inside her belly or anything. Didn't listen to lung sounds, didn't do nothing. That's terrible, because she was screaming. With that said, that's how easy it can happen. I've known this guy for 3 or 4 years. He's been in the system. And he knows distracting injury. Okay, so it can happen. Don't let it happen. Teach yourself. Let's say, hey, you shut your face. Let's do head to toe. Try and talk to them about something else. Don't be rude. Evaluation must always be done of distal neurovascular function, pulse, skin color, cap refill, sensation, movement. You can't find a pulse in somebody's foot and they have a known femur fracture. Cap refill is a good one. Okay, I can't find a pulse because they weigh 600 pounds and their foot's too big, but I got cap refill less than 2 seconds. That's good enough. All right. Sensation of movement, if it's broke, you're probably not going to want to move it. They'll tell you, no, I'm not doing that. Different ways management. Splitting prevents further movement, limit tissue damage, bleeding, eases pain. Remember I said if it's bad enough, I don't splint anything. We rip them out and get them gone. If there's not a lot of other stuff where they're stable, you suspect something but stable, somebody's in pain, their heart rate's up. Well, I don't want their heart working more, especially if they're bleeding out. Your heart works more because you're in pain. They're going to pump blood out faster. That's going to hurt them. So you can't give pain meds at the EMT level, okay? You're not allowed to carry narcotics for pretty obvious reasons. And they don't just hand them out, okay? But you can splint positions of comfort. Traction splint on somebody's leg. You'll see, you'll understand it more when you do the traction splint. Those people, I don't think that there's a fracture out there that you can do something for somebody and they're going, oh my God, that feels so good when you get it on there. I promise you. You'll hold manual traction on somebody with a long bone fracture. You literally get up, they're laying flat, and you grab their foot and pull it away till they say, oh, right there. It's like petting your dog in that sweet spot. Doing that little kicking thing, you're good, okay? That eases pain, that slows the heart rate down. So if something else really is going on, it's not so obvious yet, it'll make it obvious if you pump all their blood out because they're hurting. So that's one of our biggest things. At the end of the day, EMS, pain-free. Okay, our goal is to get people down in the pain scale. You hear 0, worst pain, 10 is your worst pain your whole life. We want to get them down in the 2 or 3 region. Okay, that's acceptable. They say my pain's 10 to 10, you should be doing something if you can. Some people always say it's 10 to 10. My patient yesterday, I said, well, your pain's 0. He said 20. Okay. All right. Management. When in doubt, splint. It's difficult to differentiate fractures, dislocations, sprains. Some will be obvious, some won't be. Remember the motion. Okay. If they can't move it, pretty good sign that it's a fracture, but if they can, doesn't mean that it's not fractured. Principal spleen, don't move patients before splinting unless the patient is in danger. Remove clothes, inspect. Note record. Note and record distal neurovascular function before and after splinting. That's on anything. You put them on the KED. Y'all did that? Seated. Backboard. A traction splint. Any kind of splinting at all. Anything that you put on one of your patients, you check neurovascular function before and after and document that you did it. Okay? Principles. Cover wounds with dry sterile compression dressings. Fractures. Talk about fractures of bone. Splint the joint above the bone, above the fracture and below the fracture. Dislocation. Splint the bone above and below. Okay. Minimize movement. Support the injury until splinting is complete. Pad splinting to avoid localized pressure. So if their leg is broke and you put this on top of them, you tie a knot and double knot it right over the fracture site. That's probably not so good, okay? What's happening? You have a seizure?
I guess so. Is it yours?
Oh. All right. Padding on everything that we put them on too. I know Leroy covered padding when you put them on backboards and stuff. Padding in this as well. We'll learn next week when we do some of the legs, the way we immobilize legs, we put padding in and you'll be taught that. Angulated fractures. You can realign before splinting. Be very, very careful. Check for PMS. If you have PMS and you have somebody nearby that can give them happy drugs, you don't necessarily need to sit there and be pulling on somebody's leg trying to realign it. Because A, you're going to hurt them real bad, and you could occlude their neurovascular function. Okay. Somebody's there and they can get happy drugs on board, that's what I would do. I wouldn't try and realign until I know that I'm missing PMS. And like our local protocol says, you have the right to try and realign to regain PMS one time and then you transport. All right? Otherwise, I wouldn't be messing with it. Dislocation, splint as is, unless circulation is compromised, have to reposition once to restore the pulse. If it's resistance, pain encountered, stop, immobilize as is. With that said, when I say don't realign, if they're laying on the ground and their arm is flipped over like this at an L shape, obvious open, okay, you probably need to realign that. You're not going to make a splint that's shaped like a lightning bolt. All right? But just a little fracture where there's some kind of deformity, just they got PMS, splint it in place and go. That it? 5 minutes.
Is that it? Or do we still have one more?
We got one more.
One